Welcome to part 2 of week 1 of our course Economic Evaluation in Global Health. In the last part, we set out defining global health, looking at healthcare systems, and also looking at how different kinds of healthcare interventions fit within the system. And now we're going to look at a framework and definition of economic evaluation. So let's start out by discussing how, in many ways, all of us are applied economists. We make decisions every day that involve the balance between costs and benefits. We have to make priorities between competing choices, and we usually have a budget constraint because very few of us have unlimited amounts of money. Most of us have to work within a budget. So let's say you wanted to buy a car and the choice was between a Mercedes and maybe a Toyota. So one might look at the color of the car and might look at the quality of the seats, maybe leather or cloth seats. One might look at the speed and the comfort. So different attributes. Now, if you like different attributes, you have to be willing to pay a little bit of a price for them. So consequently, in most cases, a Mercedes is going to be more expensive than a Toyota. Now, in making public policy decisions or decisions that affect many people, it is important to put a formal evaluation on these choices if you're doing it for maybe a country or a region. And that's why economic evaluation is important. But in many ways, all of us are economists in our day-to-day lives. And this is a nice cartoon that I like. This lady was trying to assess the costs, the risks, and the benefits of her lunch. And she has a hamburger here and a tuna salad and an egg salad and some beef stew, and the costs are there in dollars, and some of the risks might be based on the amount of cholesterol and fat in the different foods, her expected risk of getting problems with her blood vessels and consequently getting cardiac problems. Now let's look also at the economic perspective on health and medical care. You can look at health care as a production function, and in general in economics, output is a factor of different inputs, and these inputs are factors of production. Maybe you have things like land and labor and the many things that capital can buy. And then for health, health is a factor of this function H, which includes things like hospital stays, doctor visits, and medications. And there's this other component, which at a population level includes social determinants of health, such as diet and lifestyle and income, which are all important things that affect how healthy one is or isn't. And individuals trade off health with other economic goods. And physicians are patients' agents, and they advise on the process. And the demand for medical care is actually derived demand from the demand for health. This means that the demand for health is further down the road from the demand for medical care. And also a little bit about the difference between economics in general and health economics. Economics is the study of the allocation of scarce resources to satisfy needs of different citizens in the economy. Health economics focuses on resources for healthcare and the role of the provision of care and of medical insurance. In economics, private markets are considered to be efficient mechanisms of resource allocation. But in healthcare, there are some problems with that market that require special interventions and adaptations to improve the efficiency of how healthcare is provided. So what's unique about the economics of healthcare? Healthcare markets have special features which make them different from the market of other products, maybe like kettles or bottles or cups or sodas. And the main difference is to do with uncertainty. And it's in terms of the efficacy of therapy, what works and doesn't work, and in the incidence of illness. These are the two sources of uncertainty. So if you leave your house and take a walk, maybe you're going to work or to a bus station, you have no idea that you might get an injury, and you have no idea that you have the background processes that might lead to a cancer happening in your body. So it's uncertain when you might get sick. And even when you get sick, doctors don't always give a guarantee that you're going to get better, even when they intervene in the healthcare system. And the other key difference is what we call information asymmetry, the idea that doctors and people like pharmacists and nurses train for a long time, and they might have an insider view on individual health. And individuals don't know as much as doctors with regard to health. Of course, that's changing in the modern era because of the internet, and people can Google their diseases, and you find that patients actually know a lot about their individual situations. However, in general, there's an asymmetry of information between providers and patients. And there are special adaptations for healthcare markets. These are interventions and institutions that have arisen in response to this uncertainty. And these include insurance and insurance regulation, provider licensure, the idea that physicians have to get licenses to practice, drug and device regulation, health technology assessment, and the subsidies for education of physicians and pharmacists that happen in many countries in the world. So let's now define economic evaluation. It's the comparison of two or more alternative health interventions, treatments, or programs in terms of their costs and effectiveness. And we stress comparison of two or more alternative health interventions, and in terms of both their costs and effectiveness. The costs refer to the value of resources involved in providing treatment or the intervention, and the consequences are in the broad category of health outcomes. And these are the health effects that derive from the intervention. So in some senses, it's about trade-offs and balance. In the middle, you have value, and on one side you have cost, on the other side you have health outcomes. And people often say that cost is what you pay and value is what you get. And in economic evaluations in healthcare, that value is represented as health outcomes. So economic evaluations ask the question of how much health outcome do you buy for a given cost intervention. Now, it's important to define a comparator. To be able to do a full economic evaluation, you need to compare. Most times you're comparing with what we call the base case, and you have to define exactly what that is that you're comparing. For specific interventions like clinical procedures, the natural base case is the status quo or standard of care, which is what people have already been doing. Now, sometimes the best case is actually do nothing. Maybe it is a problem, a clinical problem for which there has been no cure. So for example, right now there's no advanced cure for Ebola, and there's some therapies that are in the experimental stage, but really there's no true cure for Ebola. So if you are doing an economic evaluation of a medication, a new medication for Ebola, the comparator would be no treatment or do nothing. So it's probably best to define policy-based cases that are close to current reality for policymakers, and then do incremental studies from these base cases. But sometimes it's important to consider the impact of doing less. Essentially, sometimes people are doing too much or intervening too much, especially in policy, in the policy context. And we have this idea of negative intervention that can prove to be cost effective. And we'll look at an example of that when we look at the cost effectiveness plane in the next few slides. So in healthcare, you have maybe intervention A, and you're trying to compare intervention A to intervention B. And intervention A is the standard of care for the existing intervention. And normally, the new intervention is novel, or someone has developed a good idea or a new drug, maybe a drug company, and you're trying to compare to see if the price goes up, if the new intervention is expensive, how much health does it buy for you? And we consider both costs and health outcomes, as we said. Now, the gold standard measure for effectiveness is a measure that combines the life expectancy and the quality of life. And in the third week, we're going to look in detail at these health outcome measures. But there are two that do this, and one is called a disability adjusted life year, or DALY. This is disability adjusted life year. And QALY, which is quality adjusted life year. Now, QALYs are good things because essentially they mean that health is improving, but DALYs are negative in the sense that they are used to quantify disease burden. So many DALYs are a bad thing and many QALYs are a good thing. And we're going to look at exactly how this plays out in the next few weeks. So with regard to resources for healthcare, you have monetary resources and health system capacity. So you have things that you can buy easily with money, maybe drugs and vaccines. And then you have health system capacity that has to build up slowly over time. Human resources, training doctors, infrastructure, building hospitals, or even medical schools. And healthcare interventions usually need more of one or the other of monetary resources and health system capacity. So if you're working in a poor country, it makes sense that you would choose interventions that require relatively little health system capacity, because you might not be able to build this up in a short time. So if you enter a conflict situation in a refugee camp, it's difficult to build, a field hospital. NGOs like MSF, Médecins Sans Frontières, actually are very good at building field hospitals in a short time. But in general, if you were to choose an intervention, you would choose a cash-heavy intervention, which means a lot of monetary resources. And here is a nice picture that I like. If you have on this axis costs, you have resources in dollars, and you have health system capacity here. And then in health outcomes, you have disability adjusted life years, or QALYs, here. And here you have what they call financial risk protection. We talked about it in the last part. And most analyses, cost effectiveness analyses, are in this purple part. They measure the amount of resources spent to produce health. And some analysts are now beginning to do what we call extended cost effectiveness analysis, which are a combination of these two in terms of finding how, if interventions increase resources, not just how much health do they buy, but how much financial protection do they buy in terms of number of cases maybe of poverty that are averted. And we might speak a little bit about extended cost effectiveness analysis, as it is called, which is the method for adjusting for the impact of interventions on financial risk protection. So let's look now at the rationale for economic evaluation. Information on efficacy and effectiveness is necessary, but is not sufficient for making good decisions. It's necessary to consider the opportunity cost, which means the benefits foregone of alternative courses of action. And like we said, healthcare has an atypical market, and governments intervene to deliver and finance healthcare. And given scarce resources and the absence of good price signals, policymakers need methods to allocate resources between competing demands. So economic evaluation really is an instrument of public policy in some sense. And economic evaluations are useful to guide decision makers, maybe in the public sector, like we said about public policy, about whether to change the intervention mix or whether to change coverage levels. So let's say you had 3 interventions for headache, for example, you have paracetamol, ibuprofen, maybe naproxen, 3 interventions. So an economic evaluation can decide whether you should change the intervention mix, maybe remove ibuprofen, or you should increase the access to Panadol relative to naproxen, so the coverage levels. And often the questions pertain to specific health problems. But like we said in the last part, you have times when you are assessing instruments of policy, for example, or changes in the way clinics are run. And the other use of economic evaluations in healthcare is to inform health policy. And then the third one is to generate cost effectiveness generalizations to support or undermine broad generalizations in healthcare policy options. So you'll find people throw things around like prevention is more cost effective than cure, and if this is for a particular healthcare intervention, you are able to actually put numbers on that to perform an economic evaluation and decide whether the evidence supports this broad generalization that someone is making in a specific jurisdiction, maybe in a country. So policymakers need evidence. They just don't do stuff by divine intervention. They need some help, and economic evaluation helps to provide some of that evidence. And estimates of cost effectiveness and cost effectiveness provide clear guidance to policymakers when 3 things happen. One is that the effectiveness target is clear, and the economic evaluation is seeking to minimize cost, essentially. So if you can minimize the cost to achieve your clear effectiveness target, then the policymaker knows exactly what to do. In the second situation, you have a clear budget constraint. So you say, I have $1,000, that's all I have. And the aim is to maximize health benefits within that restricted budget. And the third one is when you have a clear threshold for cost effectiveness. And you've explicitly stated it, and you say, we don't pay for interventions that don't meet this threshold. So as we come to the end of this part, I would like to emphasize that cost effectiveness or value for money in healthcare is important for the rich and poor countries. So for poor countries, you have very small spending per capita. So for most sub-Saharan African countries, very few countries go above $100 per capita in healthcare spending. So given such a small amount of money being spent, and with a high burden of preventable diseases, if you misspend even a small amount of money, then you lose the opportunity to postpone many deaths and prevent substantial disability. So you lose the opportunity to avert DALYs. So that's why it's important to do economic evaluations and be able to put not just a cost estimate on interventions, but also how many DALYs you can avert with those interventions. Now, in rich countries, they have a different problem, because they've taken care of most of the preventable problems, but they have an issue with rising cost of healthcare. So in the US, essentially you have a huge amount of money being spent on healthcare. And given such a huge amount of money being spent on healthcare, economic evaluations really are to do with reducing the rate of growth of health expenditure and reducing the amount of money that the economy is spending on healthcare as a proportion of gross domestic product. And the other issue is that many new and expensive interventions are being created by companies every year, and usually the question is, should payers or health insurance companies reimburse such new products? So the point really is that cost effectiveness is not just for poor countries, it's for both rich and poor countries. So this is the end, essentially, of part 2 of week 1, and in this part we defined economic evaluation and looked at the rationale, and in part 3 we are going to look at, if you have intervention A and it's the old one, and you have intervention B which is the new one, how do you decide whether intervention B is cost effective relative to intervention A. Thank you very much, and I'll see you in the next video.